Let's discuss a question regarding pulmonary embolism. A 36-year-old woman presents to the emergency department with worsening shortness of breath and pruritic chest pain. Her symptoms began earlier in the day while she was waiting for her bus to return home. She recently returned from China to United States for a business meeting. She denies any sick contacts and has not had these symptoms in the past. Medical history is unremarkable. She takes an oral contraceptive and a daily multivitamin. Her temperature is normal, blood pressure 135/82, pulse 112, respiratory rate 24 per minute, oxygen set 89% on room air. CT angio performed and demonstrated a filling defect in the pulmonary vasculature. She immediately started on the supplemental oxygen and heparin, and this is her CT. You can just see this thing. And now let's discuss pulmonary embolism. So this question is a classic description of pulmonary embolism. We'll see how. Let's discuss first. The definition is a mechanical obstruction of the pulmonary vasculature secondary to blood clot. Typically, blood clot is a thromboembolism from a deep vein thrombosis, DVT, one of the major cause. Let's talk about few risk factors. It is prolonged immobilization, long travel, as we could see in the question earlier that she traveled from China all the way to USA for a business meeting, and there was a long travel. A malignancy, thrombophilia, pregnancy, hormonal contraceptives, or it could be OCPs, which we could see in the question that patient was taking. Patient was on oral contraceptive pills. So two risk factors that we could make out in the question that we saw earlier. So DVT, which is most common, let's talk about the etiology. DVT can be from the veins of the proximal thigh, iliac, femoral, popliteal. Iliac is the most common one. Iliac is the most common where you can get the DVT. The second thing is phlegmasia cerulodonens. It's a progression of a DVT. It is a progression from a DVT, a massive thrombus that can emboli from proximal iliofemoral vein, and typically you see enlarged blue tender lower extremity. The other could be septic emboli from the right heart endocarditis. Can you recall right heart endocarditis? Most common tricuspid. And can you recall from where this could come? It could be the most common bacteria could be Staph aureus, and you could see, yes, it is IV drug users. It's the most common. Other could be fat emboli. Fat emboli could come from the long bone fractures. Long bone fractures is one of the major cause of fat emboli. Amniotic fluid embolism. Let's talk about the pathophysiology. Occlusion of the pulmonary vasculature results in hypoxia and subsequent pulmonary vasoconstriction. The vasoconstriction is very important here, and that could also can lead to pulmonary hypertension. And hypoxia, one of the major thing that could occur. The increase in pulmonary constriction causes an increase in pulmonary vascular resistance, which decreases the right ventricular stroke volume, and this could the decrease in right ventricular stroke volume can lead to many things. The first one is increased ventricular oxygen demand, the right ventricular dilation, the decreased left ventricular preload, which leads to circulatory failure, poor blood flow to the lungs, which can lead to ventilation perfusion mismatch, which we call it as VQ mismatch. Let's talk about how does this patients present. The symptoms could be dyspnea, which is the most common, short of breath, which we also saw in the question earlier. Pruritic chest pain, which we also see in the question. Cough, hemoptysis, syncope in case of a large pulmonary emboli. A large pulmonary emboli can also block the bifurcation of the pulmonary arteries. Physical exam could show tachypnea, tachycardia, which we saw in the question, which was there. Loud P2, it could be because of the pulmonary hypertension thing. Hemodynamic instability in case of again large pulmonary emboli, which we can see that it blocks the bifurcation, which we also call it as a saddle pulmonary embolism. Let's talk about the imaging findings. CT angio of the chest. This is the choice in the diagnostic evaluation in the pulmonary embolism, because the sensitivity and specificity are 90 and 95% respectively. So it is the choice of diagnostic test here. So if we do chest radiography, it's typically normal, or it may show pleural effusion, Hampton hump, which is a wedge shaped infarct, a Western mark sign avascularity distal to the pulmonary emboli. Not that commonly tested in the exams. Let's talk about the VQ scan. When we do, what are the indications of VQ scan? It is performed if a pre-test probability of pulmonary embolism is high, but patient cannot undergo CT angiogram. Who are the patient who cannot undergo CT angiogram? Those are the renal failure patient, pregnancy patient, or if there is unavailability of CT angio, then those patient. And most commonly, which you're gonna be tested in your exams, would be the pregnancy. The pregnant female comes with the symptoms of pulmonary emboli. What will be your next step of management? It would be VQ scan. Please remember this point. Now let's talk about if the VQ scan is normal, you rule out pulmonary embolism. If it is high, probably treat with heparin. If it is low or intermittent, probably. If clinical suspicion is high, then get a pulmonary angiography. Anyways, venous duplex ultrasound of the lower extremity to check DVTs. Yes, to evaluate if there are any DVTs there or not. The other thing you can do is ECG. Let me tell you, majority of the cases ECG will be normal, or it could show only sinus tachycardia. Few cases can show atrial fibrillation, and if there is right ventricular strain, if the right ventricle is straining, the right side of the heart is straining, if we considered it as a high risk pulmonary embolism. And another specific finding, it is rare but it is usually tested in your exam, it is S1Q3 T3 finding. It is presence of S wave in lead 1, Q wave and inverted T in lead 3. So it is S1Q3 T3. It is the most specific finding, could be assessed on exam, but majority of exam can show sinus tachycardia or ECG is normal. If you obtain ABG, arterial blood gas, it would show hypoxemia, hypocapnia. Hypocapnia is a low partial pressure of carbon dioxide in the arterial blood. This could be because of the increased respiratory rate. If there is high respiratory rate, the amount of carbon dioxide from the blood, it is going to move out from the lung because the respiratory rate is high. And because there is low carbon dioxide in blood, or the hypocapnia, it results in respiratory alkalosis. Alveolar arterial, what we call it as AA gradient. AA gradient may be elevated. Let's talk about D-dimer. It has high sensitivity but poor specificity for pulmonary embolism and a high negative predictive value. So we only use it to rule out pulmonary embolism. So if D-dimers are not high, the chances of pulmonary embolism is low. If D-dimer is high, we cannot assume that pulmonary embolism is diagnostic. So if there is low pre-test, a positive D-dimer is a low risk patient, and usually followed by a confirmatory study. Let's talk about the two important differentials for the pulmonary embolism. One is the myocardial infarction. The differentiating factor would be coronary angiography demonstrate coronary occlusion, not the pulmonary vasculature occlusion. The other one is costochondritis. This is the most common when there is mild pulmonary embolism. The differentiating between the mild pulmonary embolism and the costochondritis is very difficult. And differentiating factor would be pain with palpation or movement of the arm. And in pulmonary embolism, it would be pruritic chest pain. Let's talk about the treatment part of pulmonary embolism. Non-vitamin K anticoagulation is the most common. And the indication is initial therapy in patients with pulmonary embolism in order to prevent further clot formation. Treatment should not be delayed. The medical options, the best initial step in the high risk patient with obvious PE. And you could go with low molecular weight heparin, but just remember that do not give in renal failure. If patient has renal failure, do not go for low molecular weight heparin. There is unfractionated heparin. It is dosed is monitored by the APTT and preferred in renal injury or renal failure. So always before starting low molecular weight heparin or the heparin, you always check the patient's kidney function. And if kidney functions are normal, you go for heparin. If the kidney functions are normal, you go for low molecular weight heparin. And if kidney functions are impaired or there is some kind of chronic kidney disease going on, you could go for unfractured heparin. The warfarin. Now, when do we give warfarin? It is typically given around the same time. Remember, is the same time as non-vitamin K antagonist is given. A dose is based on INR, so we can monitor it with INR, or we can also say it as PT. So what we do is we initiate heparin and warfarin at the same time, and what we call this as a bridging treatment. So we bridge both the things. And why do we have to do that? Because bridging is important here. Heparin, usually the warfarin takes little longer time to act, to get in the blood and do its activity. Until that time we can have heparin to do its work, and then the warfarin can take over. So the other treatment is thrombolytic therapy, and it is indicated, it is performed in patient with pulmonary embolism who is hemodynamically unstable. So if it's unstable, we can go for thrombolytic therapy. Let's talk about few operative one. The embolectomy indication is it is performed in patient with pulmonary embolism who are hemodynamically unstable, and thrombolytic therapy is contraindicated or who fail thrombolysis. And there we do embolectomy, IVC filter, inferior vena cava filter. It is indicated. It is performed in patient with pulmonary embolism who have a contraindication or failure of anticoagulation. Now let's talk about the Wells criteria. How do we diagnose the pulmonary embolism? It is used to assess for the risk of pulmonary embolism. Let's see. We give 3 points if there are signs and symptoms of DVT. Let's talk about the questions. It had signs and symptoms of DVT. So yes, so 3 points we can give here to our patient who we saw in the starting, the question that we saw. The pulmonary embolism is most likely diagnosis. Again, +3 we can give because in question it was most probably the diagnosis is pulmonary embolism. Pulse rate more than 100 in our patient, it was 112 I think. So 1.5 we have to add. Surgery within 4 weeks or immobilization for the past 3 days. It is uncertain, so let's not give here the point. Usually we give 1.5. Previously diagnosed PE, pulmonary embolism, or DVT, you can give 1.5 points more. In our patient, it was not the case. Hemoptysis, you give 1 point, which is not in our patient. Malignancy with treatment in the past 6 months, which was not in our patient. So the total here would be 7.5. Let's talk of less than 2 points. It is low risk, 1.3% incident of pulmonary embolism considered using D-dimer. 2 to 6 point, it is moderate risk, 16.2 incidents of pulmonary embolism considered high sensitivity D-dimer or CT angio. And more than 6 point, which we have in this in our patient, is high risk, 37% of incidence of pulmonary embolism, and we considered CT angio, and that's what we did in our patient as well. So this is all about pulmonary embolism. Thank you.